whenever you want to begin, you can begin.
Yeah, we can start now. Okay. So I'll start sharing my screen. Yeah. Right. Is my screen visible, Mansi?
Yes, sir. Yes, sir.
Right. So good morning, everyone. This is our Grand Rounds part 27th one. As usual, we'll start with the short case first, then go to other cases. So the first case is a story of a 23-year-old man. His complaint started as stiffness of both legs since the age of 15 years. He also noticed unsteadiness in walking for the last 5 years. His complaints were gradually progressing. There's no sensory or sphincter complaints. There is no positive family history of some illness. So I'll show the video of the patient. Ocular movements were all normal. Rest of the failures were normal. And the tone is normal in the upper lip. Or it's also normal. He had mild incoordination in the left upper limb, right upper limb. There's a mild incoordination right upper limb as well. Limitation, more evident. The lower limb, the tone is spastic. The power of the lower limb, the proximal muscles show good power. The knee extensions are all good power. He has contracted the tender Achilles so that the dorsiflexion was restricted passively. I can't move it. Made it a bit of no movement beyond 90 degrees. Beyond 0 degrees. Up to that is range of movement is only up to that level. But in that range of movement, the dorsiflexion was weak. You could overcome the dorsiflexion.
This is good power. Okay, please. That is good. Okay.
EHL was weak bilaterally. Also, the flexor pollicis longus also weak bilaterally. Underflexion was also weak, but dorsiflexion was more weak than the panda. The upper limb was and lower. Lower limb was really much more this than the upper limb, really exaggerated. And legs are also at risk. And the plantar response was fine. To save 10 sensations were all normal, the upper limb and lower limb. Able to feel safe is also normal. Look at the gait of the patient. The picture once again. Yes, but a tremendous spasticity. both the lower. But mental pressure power is good. It is able to stand on toes, but not on heel because his heel got contraction. So these are the findings. So what do you think? On examination, it's got spasticity of both the lower limbs, severe spasticity, mild incontinence in the upper limb, lower limb contracture of the tendon Achilles, weakness of dorsiflexus, EHL, FPL, and pantoplus relatively good power, and sensations normal, and gait also. So what do you think the likely possibilities you keep in mind? It's a short case, long duration, more than 8 years. Anyone would like to voice out? Can the people unmute and speak, Nancy? Anyone can unmute, please?
Yes, sir, I have allowed them to talk.
Okay, okay. Yeah, this is not a problem case, this is a simple case. Can anyone tell the possibility?
Sir, patient has
Severe spasticity, yeah.
And possibility are sex.
But at sex, the main thing should be, I agree with this spasticity, but lower limb ataxia was not that dominant. And such is a possibility which we can consider. And the angle, usually they get absent angle check and bed sensation is possible. But that's a possibility you have to keep in mind. Yeah.
Possibility of HSP versus
Yeah, that's first possibility because severe spasticity is the dominant one. Ataxia is minimal effect out. And most likely with the distal muscle weakness as well. More likely HSP or HSP plus is likely diagnosis. Other possibility one can consider is a topical spastic paraplegia. Okay. Now, what investigation would like to do in this patient?
HTLV2.
Okay, that test is done only rarely in India. But what's the common thing we can do in this patient to detect? Okay, I'll show the investigations. This is the MRI of the patient. Look at the MRI very carefully. That clinches the diagnosis. Okay, this is flare. This is T1. Shows in the second flare showing hyperdensity is the motor cortex on the left side. Again, you can make out the hyperdensity in the hand knob area as well as hyperdensity in the subcortical white matter area. And there is some area of hyperdensity in the diffusion also can be seen there. This is not seen in the ADC. And this is the sagittal cut of the picture, T1 weighted. This is again a close-up view of the T1 weighted sagittal cut. So any thoughts? What is the diagnosis?
Again, HSP with the Valerian degeneration.
Yeah, HSP. What type can anyone tell? HSP is likely a diagnosis. But there can be other possibilities. Topical spastic paraplegia or other condition like Sachs disease, which can sometimes cause spasticity, serious spasticity. Now I'll give the clue to this patient. Come back to the first video. Did you suffer hyperdensity here in the anterior part near the frontal sign?
Sir, ear of Lynx sign.
Exactly, very good. That's called the ear of Lynx sign. And this I have not seen before. This is another finding which can occur in HSP, the hyperdensity in the motor cortex. And one more thing, very interesting finding, one finding which we have not seen is that it's got a thin corpus callosum. This corpus callosum is very thin. Did you see that? That is called the ear of lynx. Is that type of a cat in which from the ear you find a tuft of hair going up like that. Ears of lynx sign refers to abnormal T2 or fair cone-shaped hyperintensity at the tip of frontal horn of lateral ventricles in the region of fossa spina, which resembles the tuft of hair crowning the ears of lynx. This is the MRI picture showing this is the T2 showing the hyperintensity. It is T1, it would appear like a black thing. This is again T flare only. The sign is seen heterospastic paraplegia within corpus callosum, a form of heterospastic paraplegia associated with mutation of the spastic paraplegic gene SPG11. The protein is patasthin. I forget about the gene and all. The sign may also be seen SPG15, another hereditary spastic paraplegia, which is caused by mutation of the zinc finger 5 domain containing protein encoding spasticity. And this ear of lynx sign can also be seen in Marchiform and Bigname disease. Okay, that's only a short case to nothing much to nothing challenging in that. It only to begin with. I thought I'd show you a short case. Now I'll go to the real case. 65-year-old man. These are all real simple problems, but very practical problems which come to your OPD every day. Not diagnosing in a long-term degenerative or rare genetic diseases. That we are not seeing very common. We are seeing downright garden-related cases like which I am going to discuss today. A 65-year-old man noticed numbness of his right little finger 3 months back. This is followed 2 weeks later by inability to do fine movements with his right hand. 20 days back, patient noticed numbness of the left little finger. This was also followed by clumsiness of the left hand. Okay. Almost the same thing started on the left hand as well. And patient is not a diabetic. This is the video of the patient. Tone was normal in the upper limb. He was found to have wasting of the small muscles of the hand on the right side. Left side, Corey, no much, not very convincing. The right side is definitely wasting. Also, my record was normal, biceps normal, triceps normal. This section says, finger action says all normal. And the finger abductors was weak. Medium was weak. Crochet and umbilicals were weak. Only the crochet were weak. Long fingerprints is a good normal power. Pressure policies, longness is normal. Abducted policies, babies is also normal. Better digital is weak. Almost same thing on the left side. It's got weakness of the posterior crochet, weakness of the abducted digitae minimi, and crochet were weak. More weakness of it. See here also the thenar muscle, which policies longness as well as thenar muscles, are all normal. It's got bilateral formants. The palmar adductor, palmar adductors are also. In the references are all normal. Sensations, he had impaired sensation on the medial 1.5 fingers in the distribution of ulnar. Also impaired on the dorsum aspect of the little finger. That's also impaired there. You will point it where it becomes normal. There he says it's normal. There is it is normal. So exactly the distribution of ulnar.
ഇവിടെ വരച്ചിരിക്കുക. ഇത്
Painting on the left side. There's also vibrations also impaired ability. So, got wasting and weakness in the distribution of ulnar nerve bilaterally, which is more on the right side. Wasting on the left side, truly speaking, I was not convinced. Sensory dulling in the distribution of both ulnar nerve. So he has got bilateral ulnar nerve palsy. What is the likely etiology? Site of lesion seems fairly okay from the clinical examination itself. We can confirm by NCV studies. But here the etiology is more important. What are the etiological possibilities you like to consider? With bilateral ulnar nerve, 3 months first, second, on the left side, it started only for that last 20 years.
Whether ulnar nerve is palpable?
Ulnar nerve is not palpable but not thickened.
Okay.
Entrapment neuropathy. It's not a diabetic vascular neuropathy. Disease. What possibility? Yeah, tell me, please.
What are the movements at the elbows? Are it restricted?
Elbow movements were normal, not restricted. There's no pain in the elbow also. Okay, these are the possibility one can keep in mind. Let us see the investigations. So, NCS shows his right ulnar, the amplitude is low, as suspected from the abducted digital ligament. Left ulnar, the amplitude is normal. There's also decreased amplitude in the left peroneal from the EDB. Whether it's due to the edema or something, we don't know, but that is decreased. But there's no clinical finding corroborating with the decreased amplitude. Come to the sensory, it is not obtained in the right as well as the left ulnar. It is not obtained in the right and left ulnar. That is sensory. Then coming to the FA latencies, it is absent in both ulnar, right as well as left. So where is your localization now?
Involvement at the elbow, sir.
Yeah, maybe elbow, but what's the clue there? Nothing is there in that clue. So what do you like to do now, this patient?
EMG would be helpful.
EMG can be helpful. EMG will show innervation ulnar nerve distribution. Everything is fitting with the ulnar nerve. Then EMG is not required. We want to know the etiology, that's more important. We know ulnar nerve is affected. But more
MRI both ulnar nerve.
MRI the both ulnar nerve. It's a good thing which you can do. But where will you take it? From above down, or at what level will you take it?
Is it a radicular involvement, ma'am? Sir?
It is not radicular at all because exact distributions in the ulnar nerve. Because if it is a radicular involvement, for example, CA-D1 involvement, we expect thenar muscles to be affected, and moreover, you don't expect a sensory involvement in the ulnar.
Sir, were there any subluxation of the ulnar nerve?
Subluxation was
We'll go for the blood investigation, sir.
okay. We'll go for the blood.
Sir, in him, sir, left ulnar motor is normal. Still, ready that FAV is absent, sir.
Yeah, well, that's what is good. Ulnar, can you tell that point once again?
Sir, anyway, right ulnar motor is very less, sir. We can expect that FAV can be absent on that side.
Okay, exactly.
Left-sided motor, the amplitudes are normal, sir. Still, radical that FAV is absent on the left side.
Yeah, but
is it take to the radical involvement, sir? Proximal.
No, that will not take to radicular involvement. Radicular involvement you can diagnose when there is weakness and the motor involvement is affected, but sensory is preserved.
Okay, sir. Sensory is
here sensory is affected. Moreover, amplitude should be affected wherever the site of lesion is, from the antidefoncal down to the root or plexus. Everywhere where there is a weakness, you should expect a decrease in the amplitude.
Okay, sir. Okay, sir.
Sir, Dorsal ulnar cutaneous nerve was involved, sir, in this.
Yeah, it was involved. It was involved because you got sensory loss in that area. When the video you saw, the sensory involvement was the dorsum of the finger, exactly at the level of the dorsal cutaneous nerve, is also affected.
Above elbow stimulation, did it was it normal, sir, amplitude by imaging technique or something, whether we can localize the area?
Okay, perfect. We'll come to that. Okay, perfectly right. So when he came with some blood investigation, these are investigations. Hemoglobin HbA1c was 5.3, ESR was normal, HbA1c everything normal, ANA profile was normal, and serum protein electrophoresis are also normal. So what else you need in this patient? So go back.
Nasal scrape is okay. Leprosy.
No, we want to first of all find out where is lesion. That's more important because that gives a clue to the etiology. Okay, let's see why the left wave is not obtained in this patient. Have you thought about that possibility? See, he has got normal CMAP amplitude on the left side, but the left wave is not obtained. That means there must be a lesion proximal to your elbow region, proximal to the proximal stimulation. There must be some conduction block there. Otherwise, why should the FA not be obtained? You got the point. So that every point of the electrophysiology becomes important in cases like this. See, just like when I last time also told about what Kimura told me, the golden word is that when you get weakness with the normal CMAP amplitude, there is conduction block. Somewhere there is a conduction block. So this is another clue that left wave is not obtained in the presence of normal CMAP amplitude. That means the lesion should be a demyelinating one proximal to the site of stimulation, proximal stimulation, site of stimulation. So as Soumya suggested that this is the, let us see this is seeing the FA again not obtained. So what do we go for the inching technique? The right ulnar inching technique, the amplitude is low throughout from below and elbow. But that is suspected because it has gone on to axonal degeneration. So I want to say it's axonal degeneration occurs wherever the site of lesion is, you won't get amplitude. Whether it is distal, proximal, when there is lesion, that may won't get amplitude, will not be obtained in the inching technique. But in the axonal loss, we can't find out where exactly the axon is disrupted. So this is the inching technique on the right side. But let us see the inching technique on the left side. See exactly 1 centimeter above the elbow, it is decreased. At the elbow, sorry, at the elbow, it is decreased, not above the elbow. In ulnar Hansen disease and all, you get lesion above the elbow. Here, exactly at the elbow, the cubital tunnel is the site of lesion. See, this is inching technique. You can see the good CMAP amplitude. Exactly at the elbow, you find the amplitude has come down. So, shows a conduction block at the elbow on the left side. So, what do you do when for an ultrasound in the right elbow? It was already done earlier. So, there's a bulky and patterning of the right ulnar. Notice the medial epicondyle level and the wrist level. Hypoechoic pattern is due to edema. The features consistent with the cubital tunnel syndrome. So, that is the opinion from the ultrasonologist. So, we know whether it's a lesion is in the cubital tunnel. There is no obvious thickening or tenderness there. No patches. So, they have to think of the commonest cause of cubital tunnel syndrome is entrapment neuropathy. Now, coming what is it actually caused the entrapment neuropathy? Why should we talk about this old man now? Is it due to increased carrying angle or to this elbow problem, as somebody was pointing it out very perfectly? So for the elbow, there is no increased carrying angle. It is all same, no difference between the two, and it's quite normal. So, and went back to the history, the patient used to keep his both elbows in the table while walking, like as if it was touching the table all the time. It was because of the lockdown period and all. Most of the time he's working at home, not going out, doing this work, kind of a work. What kind of a work I forgot, but he was asking you doing that most of the time. So in fact, what he had was an entrapment neuropathy at the cubital tunnel, which is more severe on the right side, went on producing axonal degeneration. It is left side. It is only produced a conduction block due to demyelination. So, any questions in this case? Questions, comments?
Sir, if this patient came little late, sir, and if left side also axonal degeneration have happened,
Yeah, you would have
Then-
gone out axonal degeneration. Yes.
yeah, then how could you have approached this patient?
No,
If
that
left-
will be difficult. That will be difficult. That's once
Okay.
axon is disrupted, we can't localize by inching technique or a demyelination. It's only by there is a focal lesion there in this nerve involved in the myelin sheath. Then only we can find a conduction block or can find the difference in the latency to find out where the site of lesion is.
Sir, can I have one comment?
Yes,
I'm Dr.
please.
Bhavin. I'm Dr. Bhavin Upadhyay from Baroda, Gujarat,
Yeah, please.
and
Yeah.
I'm your regular attending of this seminar.
Yeah.
See, in Gujarat, in Baroda, where I'm practicing, we get lots of patients from Surat, who is the diamond hub of India, and we see lots of patients who are diamond sorters. And by doing diamond sorting, they have to raise the elbows on the table and then they do sorting. So
Yes.
now they have been specially named as diamond sorters neuropathy, and they all have ulnar cubital tunnel syndrome. Just an observation I'm sharing with you.
No, perfect. Your observation is perfect. Just like I can tell you one more instance. We got in central Travancore, there are a lot of Christian families. So after the death of a person, they keep the dead body in that place, and all the relatives sit around the dead body with elbows, and this whole night they sit there. They don't lie down. Sit there with elbow placed on the table and sleep. They sleep on that elbow like this. As you said, just like what you were telling, the diamond people were sitting and doing the work. They keep the elbows on the table or the whatever place they are sitting, and then sleep off because they are not allowed to lie down because they have to moan. Moan means MORUN. They moan throughout the night. So they sleep in that position. Next day, many of them will develop bilateral palsy, just like your case. So this we initially call morning palsy, not the classical morning, MORNG, MOURNG. Morning means a crime, no? Morning palsy. Your observation is perfectly right. So it's all depends upon your occupation, the way the patient is working. Good. Any other comment?
What is the treatment that you have suggested?
No, I just put it because it's only a conduction block on the left side. He's not diabetic. I put him on a short course of steroid and told him not to do that kind of a work again. Don't put any pressure effect on the elbow. Make sure that is not done. That's the things I advise.
So what were the sites of stimulation of the ulnar on the left side, sir?
It was inching technique from the one.
No, initial, sir. Initial, the first one before the inching technique.
Initially, it was the conventional one which we did. Usually, what we do from the distally and proximally at the elbow, we did. This is just above the elbow, you have to stimulate it. So they got a stimulation, they got satisfied and then came off. See, because we are not doing the conduction biology, we are interested in electrophysiology. So here, when you suspect that, you have to instruct them to do that. Because this first NCV, the patient came with the NCV. So then only we have to rethink and ask them to do inching techniques again. Okay.
Sir, in inching technique, sir,
Yeah.
whether only that latency prolongation, whether that will help, sir?
No, latency prolongation also because the amplitude. The amplitude will come down, just like the previous issue, the amplitude one. See,
Okay, sir.
the amplitude has just come down, showing a conduction block at that level. If there's latency prolongation also is important, even if there is no decrease in the amplitude.
Okay, sir. Okay, sir.
Yeah.
Thank you, sir.
Shall I go to the next case? It's a story of a 34-year-old man. He complains of pain in the left leg, but he was very diffuse pain, not characteristic of a root pain or anything. While walking for the last 3 months, he noticed difficulty in walking for the same duration. No sensory or bladder complaints. This is the video of the patient.
ചുമ്മാ ഇട്ടാൽ മതി.
Just put spasticity of both lower limb. Since he was not completing the upper limb, I started except the lower limb first. But then seeing the spasticity like the upper limbs were not spastic, normal tone.
ഇവിടെ പിടിച്ചോ. ഈ കാല് പൊക്കിക്കേ.
The power of proximal muscles were normal.
കിട്ടോ. ഇത് പൊക്കെ. ബലം കൊടുക്കും. അത് വിട്ടോ. ഈ മുട്ട് മടക്കിക്കേ.
Knee extents are also normal.
നൂർക്ക് ചവിട്ടി മാറ്റല്ലേ അതേപോലെ ഇത് മടക്കി ചവിട്ടി മാറ്റണ്ടേ. ചവിട്ട് മുമ്പോട്ട് ചവിട്ടങ്ങോട്ട് പറഞ്ഞ പോലെ കേക്ക് രസം മാറി പാദം മുകളിലോട്ട് എടുത്ത്
Dorsiflexion was also normal.
മുകളിലോട്ട് പിടിച്ചേ. അതേപോലെ
The dorsiflexion was not normal. It was weak slightly on the left side than right side, but mildly weak.
മുകളിലോട്ട് പിടിച്ചോ. പിടിച്ചോ. ഇത് പിടിച്ചേ.
Extensor pollicis longus also mildly weak.
ഇതിലോട്ട് മടക്കിക്കേ.
Flexor pollicis longus was normal.
മടക്കിപ്പിടി. മടക്കിക്കൊണ്ടിരിക്കേ. ഇങ്ങനെ ഇരിച്ചോ.
Like entirely normal, I could overcome a little bit. It's weak on the left side. Sorry, it is weak on the left side.
നീ പാദം ഇങ്ങനെ ഇരിക്കണം.
Inversion was weak bilaterally. It is weak.
ഇങ്ങനെ പിടിച്ച് നിർത്ത്.
Yes, weak bilateral.
ഇനി അകത്തോട്ട് പിടിച്ച്.
Inversion was almost normal in the right side, weak on the left side.
അത് പറ്റും. ഇത് പിടിച്ച് നിർത്തിക്കേ. പിടിച്ച് നിർത്ത്.
That is weak on the left side.
ഇവിടെ ഇൻവേഷൻ ഒക്കെ പോയി. ചവിട്ടിക്കേ.
Anterflexion was also weak, but better than that of
ചവിട്ട്. ചേർത്തങ്ങ് വെച്ച് അകത്തെ സമ്മതിക്കരുത്.
adductors are normal.
നിങ്ങൾ എഫേർട്ട് എടുക്കണം. കാലകത്തി വെച്ച് അങ്ങനെ പിടിച്ചോ. അടുപ്പിക്കാൻ
Also
സമ്മതിക്കില്ല.
appears normal. I don't know if it's operation, but it appears normal.
തള്ളിപ്പിടി.
Knee extensor is also normal.
തള്ളി ഇതാക്കണം. ബെഡിലോട്ട്. കീഴോട്ട്.
Good power.
ഇത് തള്ളിക്ക്. തള്ള വിട്ടെ. This is one finding, you know. See the knee towards hyperextension കണ്ടില്ലേ.
Knee jigsaws exaggerate. Diagonal jigsaws are also brisk bilaterally. The plantar was flexor.
കാല് വലിക്കല്ലേ.
Try to make it extensor, it is always flexor.
ഈ കുത്തുന്നതൊക്കെ അറിയാം.
Primary modal sensations are all normal.
കുത്തുന്ന അറിയാവോ? ഒരേപോലെ വ്യത്യാസമില്ലല്ലോ. ഇത് ശ്രദ്ധിച്ചിരിക്കണേ.
Vibration was normal in the upper limb as well as the lower.
ഇപ്പോഴോ? ഇപ്പോഴോ? അറിയാമല്ലോ. ഇത് അറിയാമെങ്കിൽ അറിയാം. ശ്രദ്ധിച്ചിരിക്കും. ഈ കുത്തുന്ന അറിയാമല്ലോ. ഈ കുത്തുന്നതും ഇതും ഒരേപോലെ.
There's no difference in the toes and the thigh.
അസുഖം മാറി.
But the joint presence was impaired bilaterally.
ഇപ്പൊ എങ്ങനെയാ? ഇപ്പോഴോ?
This makes mistakes.
പറഞ്ഞുവിടാം. ആൾക്കാർക്ക് പറഞ്ഞാൽ പോരെ. ഇപ്പൊ എങ്ങനെയാ? ഇപ്പോഴോ?
Yes, I can make mistakes.
ലൂസാക്കി. ഇപ്പൊ എങ്ങനെയാ? ഇപ്പോഴോ?
Taught him once again, be sure in the upper limb was normal. Each the kick in, the lower limb he was making mistake.
ഊന്നാണോ? കറക്റ്റ്. അപ്പൊ ശ്രദ്ധിച്ചിരിക്കണേ. ഇപ്പൊ എങ്ങനെയാ? ഇപ്പോഴേ?
You can make mistakes.
ഇപ്പോഴോ? ഇപ്പൊ പിരിവിരിപ്പുണ്ടോ നിനക്ക്? ഈ കാലൊന്ന് പൊക്കിക്ക് മുകളിലോട്ട്.
SLR was negative.
വില കൊടുക്കാതെ.
Abdominal pressure all intact.
പിടി. നല്ല പോലെ
I check the power against it, the upper limb is normal.
എന്തെങ്കിലും പ്രവൃത്തി ചെയ്യാൻ ബുദ്ധിമുട്ടോന്ന് ചോദിച്ചാൽ അതാണ് പറയുന്നത്. അങ്ങനെ പല കയറിയും പറഞ്ഞിട്ടുണ്ട്. കഴിയാൻ അങ്ങനെ പൊക്കി പിടി. നൂത്തേ വിട്ടോ. കടിക്കാൻ അകത്തി പിടിച്ചു. അകത്തി പിടിച്ചു.
The radial muscles are normal in the upper limb. The upper limbs were normal. That's already shown earlier. The lower limbs were brisk. Look at the gait. Yes, got spasticity more on the left side. Spasticity.
Definitely.
More spastic on the left side. Complex side note sheet was negative. So on examination, motor system, spasticity of both upper limbs, left more than the right. Weakness of both plexus, EHL, extensor pollicis, not extensor pollicis, sorry, flexor pollicis longus, and evertus bilaterally. Weakness of both hip extensors, abductors, I'm not sure. Just mildly weak, but I'm not sure about that thing. DTR upper limbs normal, lower limb brisk bilaterally, plantas, abdominal fluid present on all four quadrants, plantas going downward, sensory impaired, all senses normal except the impaired joint sense on both feet. Rhombus is negative, gait is spastic with the left more than the right. So what is a localization in this patient?
There's a predominant involvement of upper motor neuron motor weakness with dorsal column involvement, sir. In view of upper limb involvement, the lesion should be around the cervical region. Most probably, the spasticity is.
In upper limb, there was no spasticity. Upper limb tone is normal.
Then, yes, sir. Around the dorsal column involvement with the motor involvement below the cervical region.
Yeah. But it could be even cervical also. So the thing is that we only know that you have got a pyramidal lesion above L1, where we don't know. It can be at L1 or can be above L1. Just because abdominal fluids are preserved, we need not necessarily be point to a lesion at D12 also. Secondly, it's got impaired posterior column in the distal part. It may be the beginning of a posterior column involvement at any level. Even a high cervical cord compression may start with impairment only in the distal part. As the disease progresses, the impairment may become more and more evident or spread proximally. So as you said, lesion is somewhere above dorsal cord. That's all, the lower dorsal cord. That's all we can say. We cannot rule out a cervical cord, as he said correctly. We can't rule out. So we can only say this much. That is myelopathy above L1 plus posterior column affection. That's a very broad, unlocalizable statement. That's all what we can say. So what etiological possibility will you consider? Is there a peripheral lesion in addition? Peripheral neuropathy like lesion?
But the reflexes are preserved in spite of absence of posterior column.
Exactly. The reflexes are preserved. That's a point against peripheral neuropathy. But always keep in mind that the conditions like, for example, subacute combined degeneration, there can be myelopathy plus peripheral neuropathy. When the myelopathy is dominant, the reflex may not be lost if it is a mild peripheral neuropathy. Peripheral neuropathy is very dominant, reflex will be lost. In the presence of a pyramidal lesion where the reflex are already brisk, associated peripheral neuropathy, which is mild, may decrease the reflex, may not make it absent. So why I was telling like that? See, his weakness was only confined in the distal part. Even the flexor pollicis longus was also weak. That's certainly odd for a pyramidal type of distribution. So you have to keep that possibility in the back of the mind. Are we missing a peripheral neuropathy? Because we are not proved to that. No, this is only, as what you said is correct. With the findings, we have no definite evidence of any peripheral nervous system involvement. But you have to keep that possibility in the back of the mind. Yeah. So what etiological possibility will you keep in mind?
First, we have to rule out the compressive, sir, then the non-compressive causes.
Okay. But compressive, is it likely because yes, but abdominal reflex is intact, his plantar is downgoing, and spasticity is dominant. Okay, the compressive is possibility, but this disparity, selective involvement of the pyramidal system, where the plantar is definitely downgoing, not at all upgoing, in preserved abdominal reflexes, and only the spasticity and weakness. You have to keep it first, but non-compressive also you have to keep in mind. Yeah. But anyone? Please, I can't hear. Bindu?
Nutritional B12.
B12 deficiency is a good possibility where you can have pyramidal viscosity, and it can be maybe supplementary peripheropathy may be in that we have to investigate.
So other cause could be the tabes dorsalis test of presentation. In view of the age, sir, syphilis would be one possibility.
Tabes dorsalis hardly have a weakness of this unless there is a taboparesis. Tabes dorsalis, the dominant thing is sensory ataxia. Lost reflexes and sensory ataxia. That is not the picture here in this patient. He has no ataxia at all. The posterior sensors are mildly affected. B12 also expect. B12 can have various. Okay, some of them can have predominant sensory ataxia. Some of them can predominant pyramidal involvement. So that picture can be varied in a B12 deficiency.
Could you suggest stiff person syndrome, but only sensory is a little abnormal?
Stiff person syndrome, sensory is abnormal. Moreover, he has got definitely weakness is there. The lower limb he has got weakness.
Sir, had he undergone any surgery in the recent past?
Surgery? No.
Recent past. Any excessive?
No. No, I did not. Did you ask about the surgery? No, he did not have any surgery in the past. Okay.
Sir, to consider B12, sir, the predominant distal weakness is against for B12.
No, that's not again. That depends upon whether got a submental peripheral neuropathy. That can occur. Distal weakness can occur.
In this case, sir, with preserved reflexes and predominant wasting.
Yeah. And that's what initially I told you. The pyramidal signs are very dominant, and the peripheral neuropathy is mild. You can have a distal and preserved reflexes. Some time back, I showed a case of, I think last week or so, a severe sensory ataxia patient with brisk reflexes due to posterior column involvement. Okay, that patient had no context abnormality in the distal part. That possibility we'll keep in mind. Okay, agree. So the etiology may be subacute combined degeneration. Can we do tractopathy due to paraneoplasty? Whenever it is selective tracts involvement, which is not fitting with the compression, like a selective pyramidal tract involvement, selective posterior column involvement, we have to keep this possibility also in the back of the mind. And less likely to be compressive, you have the selective pyramidal infection with non-linear trancus. But that possibility cannot be ruled out. A compressive myelopathy can have varied presentation. So, what as you know, NCS was done, which is normal, except that his right peroneal amplitude was decreased. Whether that is significant or not, we don't know, but that was decreased. But he had no sensory conduction was normal. So that is unlikely for a peripheral neuropathy due to subacute combined degeneration. We expect sensory neuropathy to be affected, not motor. So that conduction abnormality may not be very significant, only 1 hour affected on one side. FF latency is also normal. So what else you need now?
MRI followed by CSF.
Yeah, MRI was done. This is the MRI cervical spine. Initially, I thought there was some hyperdensity in the cord, which was not when the radiologist was not agreeing for that. He said there's no hyperdensity, it's an artifact only. Thoracic cord was normal. Lumbar spine was normal. This is axial cut of lumbar cord. So what do you want now? I said I want a thin cut for the cervical cord because I want to rule out subacute combined degeneration. So I did a thin cut, and the special, it's called a flare and what do you call it? Gradient, special gradient sequence. Again, there was no hyperdensity in the cervical cord. Even gradient sequence happened very prominent here. That was not there. It's a T and weighted. Axial cut also did not show any hyperdensity within the cord. And they take an MRI brain. I don't know why they took an MRI brain because I never asked for the MRI brain. This MRI brain showed huge hydrocephalus.
That sagittal cut itself shows that it is very atrophied kind of.
Which one?
The first SAGs that you have taken, that shows that the upper side, no, middle and the pons is so thin.
In fact, that is not picture is not for that area. That so we cannot. It may not be
Yes,
that, that we cannot comment on that. We'll take that.
Okay, sir.
Let us see the we have got the MRI brain. In fact, they did not comment on that. But this is the MRI of the brain. So, what do you think the possibility now?
Can explain, sir, the predominantly involved the
How
lower
was
limb,
HIV,
fibers.
sir?
Pardon?
HIV done?
HIV? No, HIV was not done.
The congenital.
Yeah, that's the first thing you have to find out is find abnormality. Does it corroborate clinically or not? Does the hydrocephalus explain the physical findings in this patient? Absolutely no. We cannot explain that. We cannot explain the findings. Second thing, look at the hydrocephalus. This is not obstructing hydrocephalus. This is hydrocephalus which is arrested hydrocephalus. There's no seepage, nothing. And it has been there for many years. This is called arrested hydrocephalus. So it is not explained. So what do you want? And the MRI spine, cervical spine is normal.
Yes,
Paraneoplastic antibody screen.
Yeah, we have to send for paraneoplastic. But before the common things, what you have to do?
CSF.
Yes, sir.
And the vitamin B12, no. Vitamin B12 is 534, normal.
Homocysteine and copper.
Homocysteine.
Yeah, correct. Homocysteine was very low, was markedly increased, 27. Upper limit is 16. So this have time and again, I think we have seen that when there's a vitamin B12 deficiency, the vitamin B12 can be even elevated. In fact, there are many articles on that point because the method of estimation you can show spuriously elevated vitamin B12. So always go for a homocysteine or methylmalonic acid. So it's elevated homocysteine and the clinical picture is subacute, only 3 months duration. And so I thought more likely this is I'm not 100% certain. If you ask me why can be a paraneoplastic, only time will show. Paraneoplastic myelopathy the MRI can be normal, can be abnormal. They can show tract specific hyperintensity, confined to the pyramidal tract, confined to the posterior column, confined to the pyramidal and posterior column. But only that tract will be affected or can be entirely normal. So that possibility I cannot rule out now at this point of time. Since you have want a clue that homocysteine is elevated, so I thought we'll try with injection vitamin B12 and follow up the patient. And we have not done a paraneoplastic antibiotic profile so far. We thought we'll try and then come back again. Now the case is brought that one should not be carried away by certain investigations, strikingly abnormal, but always try to correlate with your clinical findings. Then only come to a conclusion.
Sir, one comment, sir.
Yeah, please.
After listening to last few cases, we are always doing homocysteine along with the B12, sir. Now
Yes.
we lost the belief in B12 alone estimation, actually.
Exactly. Because you just go to the literature, no? So many articles are there. Is of these pitfalls in it can be even elevated in B12.
Yeah, it was even some of your cases it was even elevated. Even this case also it is on the higher side.
Yeah, the higher side.
Yeah. Previously we will be wandering in the darkness. Now we thought it is okay. Every time with B12 we'll do a homocysteine also.
Yeah, that's always do that.
Is he vegetarian or non-vegetarian, sir?
He's a non-vegetarian. See, many times, no, I don't know why. The last week, I showed a severe incontinence patient. He was also a non-vegetarian. But the problem is that these people take Ayurvedic medicine for many ailments, and they undergo strict pathya. Pathya, in the Malayalam, pathya means they've got severe restrictions in the diet. They are not allowed to take fish or meat or egg or anything, any protein food, only some vegetables and all. So they can develop, those people undergo this fasting and pathya, they can develop this B12 deficiency. And most of the time it is not dietary. There is some factor, deficiency of which antibody, which is causing this problem.
Sir, in such patients, sir, you do, sir, folic acid also, sir, along with P12.
I did not hear. Can you tell it once again?
Sir, in such patients, sir, folic acid also we do, sir, along with B12.
Yeah, we give folic acid along with B12, but never folic acid alone. You have to combine folic acid with, B12 with folic acid.
Should we rule out pernicious anemia?
Yeah, we should rule out. We should assess for the antiperitoneal antibody should be done in this patient. And then previously I had showed one that showed the patient once again. He had come with remarkable improvement with B12. His antiperitoneal antibody, he was a non-vegetarian, but his antibody was negative. So I'll go to the next case. This patient came with history of inability to open his eyes after closing for the last 3 months. It's a short video, short case. Look at the video once again. Very carefully. Ask him to close the eye. He cannot open the eyes. Has to close tightly. Had to open. Could not open. That's the only finding in him. There's no other complaints. So Clemum is normal, no features of Parkinsonism. I'll show the video once again. Has to look down. Has to close the eyes. Has to open. Eyebrows goes up, the eyelid will not go up. Okay. Any thoughts?
Apraxia of eyelid opening.
Apraxia of eyelid opening. Everyone agrees with that. Why not blepharospasm?
There is no contraction of the orifices.
Yeah.
There is no contraction of the orifices.
Okay, correct. Perfectly right. In classical blepharospasm, you get contraction of the orbicularis oculi, and the eyebrow should come down. Correct. When there is only elevation of the eyebrows, we will think of apraxia of eyelid opening. Okay. Now let us see the video once again. I'll show the another video. Same patient. I'll show the video once again. Close the eye. Yes. You want to change your diagnosis or maintain the same?
Eyelid myotonia.
Eyelid myotonia is not like this. Eyelid myotonia, they can close it unable to open. That mimic a lesion like this, but there also you find that there will be affecting both upper and lower eyelids.
Early myasthenia causing a Bogan lid twitch kind of thing, sir.
It's not a myasthenia. There's no drooping. No, actually, it's unable to open. There is no weak. What do you call? He's closing the eyes normally, but not able to open.
Is it a variant of blepharospasm? Variant, sir?
Yeah, that's right. Very, very good. Why do you say variant of blepharospasm? What is that clue?
There is contraction of the lower auricular supply muscles.
Exactly, that's the point. Now I'll come back to you, tell you once again. Okay, that's the point I'm trying to. It's a blepharospasm, and the reason I'll tell you later. Look at the patient here. When he is asked to open the eyelids, okay, stop there. See, the eyebrows goes up, correct? That is against a blepharospasm due to an overaction of the orbicularis oculi as a whole, there are two parts of orbicularis oculi, the orbital part and the palpebral part. When the blepharospasm occurs due to contraction of the orbicularis oculi, the orbital part, then only the eyebrow will come down. The other part of the orbicularis is over the eyelid. That is responsible for your blinking. So when there is a blepharospasm confined to the palpebral part, sparing the orbicularis orbital part of the orbicularis oculi, when you get a blepharospasm, only this part will go into spasm. So when the orbital palpebral part goes into spasm, in an attempt to open that particular closed partial lid, he is raising his frontalis, and because is able to raise because the orbital part is not overacting. The orbital part is normal. So what will happen? The frontally will try to raise the eyebrows as in an attempt to correct the ptosis. You understood the point? So when there is a blepharospasm confined to the palpebral part, you will not get the eyebrows coming down. Now let's see the second video. Now look very carefully. You find this eyelid, lower eyelid on the right side, is seen to go up when he is asked to open the eyes. That means there is a spasm of the palpebral part of not only the upper eyelid, but also the lower eyelid. If there is apraxia of eyelid opening, the problem is only in the levator palpebral superioris. That is, it failed to get disinhibited. When you look down, normally the LPS get inhibited. When you want to look up, that inhibition should go off. It is not going off. It's persisting, continuing inhibition of the LPS occurring. That is why the pathophysiology of apraxia of eyelid opening. Now let us see the video once again. Now look at the lower eyelid. See the eyelid going up. See this one. Why should it go up in apraxia of eyelid opening? See the eyelid. Did you see that? Okay. So that shows that it's a palpebral. And we did an EMG. EMG showed overactivity, not only the orbital palpebral part, but also the orbitalis also showing an overactivity, but predominantly the palpebral part. So differentiate apraxia of eyelid opening from this thing. You have to do an EMG of the palpebral part of the orbitalis. So any questions?
So this goes against the Babinski's, the other Babinski signs, sir.
No, the other Babinski sign is actually occurring in a hemifacial spasm.
Yes,
That is nothing to do with the orbicularis oculi, the lower part. What is happening in hemifacial spasm is that here the cervical is supplying not only the orbicularis oculi, but also the frontalis. So in the case of a spasm due to palpebral part of orbicularis oculi or due to apraxia of eyelid opening, the frontalis is free, is allowed to contract. So it is elevated that way. In hemifacial spasm, when the orbicularis oculi contracts, the frontalis also contracts. So what will happen? It will not go either up or down. So in effect, what is happening? Sometimes the frontalis overact, that the eyebrow will go up. So it will mimic a hemifacial spasm, but that's entirely different from this picture. That is only this is confined only to the upper part. But the hemifacial spasm it will be there on the lower part of the face also is affected. But something mimics that the frontalis will be up in the case of a Babinski sign 2. Made it clear to you?
Yes, sir. Yes, sir. Clear, sir. Clear, sir.
Because the frontalis will not, it will not be only mildly elevated, not to this extent. Because the frontalis here is overactive. There is no overactive this side. That overactive is prevented there because both are contracting in the case of a hemifacial spasm. I'll go to the next case. A 60-year-old man came with acute onset of heaviness of head, blurring of vision, and imbalance. Sorry, not a woman. It's a short case. Once again, lady presented with heaviness of head, blurring of vision, and imbalance while walking. So you find a sclerosis on the left side. Eye movement very carefully. Asked to look up, look down, look to the right. Looking to the right. Looking up again.
ഡോക്ടർ കയ്യിലോട്ട് നോക്കമ്മ
കയ്യിലോട്ട് നോക്കി കയ്യിലോട്ട് നോക്കി
ഇനി അടുത്തോട്ട്
ഇനി ഇടത്തോട്ട് നോക്കി
Looking to the left side.
ഇനി വലത്തോട്ട് അറ്റം വരട്ടെ അങ്ങ് അറ്റം വരട്ടെ അമ്മ
ഇങ്ങ അറ്റം വരെ
ഓക്കെ ഇനി എടുത്തോട്ട്
Okay. What are the findings in this patient? You want to see the video once again? I will show. It's good. Doses, not correct doses. Looking up is different. Looking down.
താഴോട്ട് നോക്കി ഇങ്ങനെ വിരലോട്ട് നോക്കി
Looking to the right side, left eye down.
നോക്കി ഇങ്ങനെ വെച്ചോട്ട് നോക്കിയാ
It's not adequate.
മേലോട്ട് നോക്കി മേളിലോട്ട് നോക്കി 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 മേളിലോട്ട് നോക്കി
ഇനി അടുത്ത് അറ്റം വരെ അറ്റം വരെ ഡോക്ടർ കയ്യിലോട്ട് നോക്കമ്മ
കയ്യിലോട്ട് നോക്കി കയ്യിലോട്ട് നോക്കി
ഇനി അടുത്തോട്ട്
ഇനി ഇടത്തോട്ട് നോക്കി ഇടത്തോട്ട് നോക്കി
ഇനി വലത്തോട്ട് അറ്റം വരട്ടെ അങ്ങ് അറ്റം വരട്ടെ അമ്മ
ഇങ്ങ അറ്റം വരെ
ഓക്കെ ഇനി എടുത്തോട്ട്
Okay. Where is the site of lesion in this patient? Regarding ocular movement. Anyone?
Left the third nerve nucleus.
Third nerve nucleus.
Okay.
Yes, sir.
So all
How
of
is the
it-
pupils? How are the pupils?
Pupil is normal reacting, not dilated. Okay.
It's left
Nuclear
third now.
third now. Okay. So left third now one is nuclear third now. Any other possibility? Okay. Let's see the analyze one by one. The elevation is restricted bilaterally. Okay. Don't you agree that?
Yes, sir.
Yeah, that it is restricted bilaterally. Also look
Yes, sir.
up.
മുകളിലോട്ട് നോക്കാം
മേളിലോട്ട്
Okay. That's only possible. See, if there is elevated decision bilaterally, this has to be either in upward gaze palsy or it could be a nuclear third nerve
Nuclear.
producing bilateral elevation can be restricted in that thing. Okay, that is one possibility you have to keep in mind. So I'll ask you, what test will you do to differentiate the two? But it
Ocular
is,
cephalic.
and we'll come to that. So ocular cephalic need not necessarily be abnormal all the time, even in gaze palsy, sometimes that can also be lost. But I'll come to that point later on. But that's also a point against a nuclear third nerve. What is that point in this patient?
Ptosis.
Ah,
Ptosis.
it's got a ptosis on the left side. So that tells you it cannot be in the nuclear third nerve. So you can, if you have to postulate, you have to postulate nuclear third nerve plus the fascicular third nerve involvement in the left side. Then only you can explain the ptosis. So that nuclear third nerve alone can't explain the finding in this patient. So it can be either upward gaze palsy or bilateral section of superrectus paralysis, which come later on. What other finding did you observe in this patient?
He's leaning towards the left.
That may not be.
നോക്കിക്കൊണ്ടിരുന്നേ
No,
മേളിലോട്ട്
look at the. I'll tell you one second. The finding one.
താഴേക്ക് നോക്കി താഴോട്ട് നോക്കി ഇങ്ങനെ വിരലോട്ട്
Left eye adduction is affected.
Exactly. Now look now. The left eye adduction is restricted.
Yes,
That
sir.
it could be part of the medial rectus on the left side. But you say left eye is down on the right, or looking to the right. Did you see that? Left eye is
Yes,
down.
sir.
Okay. Now, why that left eye is down?
But on the left gaze, the right eye is down.
Yeah, I'll come to that. So in this position, left eye is down. So what could be the possibility? That means either the right inferior rectus is weak because that, or the left superior oblique is weak. So that means yes, got left superior oblique is weak on the left side. So that goes along with the third nerve. So ptosis, middle rectus weakness, left inferior oblique weakness goes with the third nerve. And let us go further again. On the left side, you see, again on the left side.
മേളിലോട്ട് നോക്കി 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 മേളിലോട്ട് നോക്കി
It's already shown. One second.
കയ്യിലോട്ട് നോക്കി കയ്യിലോട്ട് നോക്കി
Looking to the left side now. Wait.
ഇനി ഇടത്തോട്ട് നോക്കി
Now what is happening? Initially, you find the left eye was down, no, in adducted position. Now the left
Now right eye is down.
Now left eye is up.
Yes, sir.
Yeah. What does it mean?
Alternating skew, sir.
No, it's not alternating skew. You call when the skew deviation, the ocular movement should be duction should be
Intact. That's true, sir. Third is gone.
Yeah. So what does it indicate? Here, it's inferior rectus weakness. See, in this position, left eye is up, right eye is down. So it either indicate a right inferior oblique or left inferior rectus. You understood?
Right superior oblique or left inferior rectus?
Yes, sir.
Yeah, correct. It should be inferior rectus weakness on the left side or elevator of the right eye is affected. That is right inferior oblique.
Okay, okay, yeah.
Okay, that means the involvement goes in the distribution of a nerve because left inferior rectus is affected, left inferior oblique is affected, middle rectus is affected, ptosis is also there. And what is against is that it's got bilateral restriction of fluid. Okay. Right?
ഇടത്തോട്ട് നോക്കി
These are all. So left third nerve is. Now the point is that how to what test will you do to differentiate whether it's a gaze palsy or due to the weakness of the superior rectus on the other side?
Action.
Yeah, you can do it. I'll show them. No, this is the one already said. No, already said. How to look at the video once again? What I have done. The Bell's phenomenon. If the explorer close the eye, the eyeball goes up. I'll show the video once again. Okay? Look up. As far as Bell's phenomenon, this eyeball goes up, rolls up during Bell's phenomenon. That shows he has got a upward gaze palsy. So he has got, so it's established is same midbrain. He has got upward gaze palsy plus he has got a left third nerve. This is the site of involvement here. Okay, any questions in that case? Any doubts, questions?
Why were the pupils not affected?
Usually in people may or may not be affected. It need not necessarily be affected. Sometimes it can be affected, sometimes may not be affected, depending upon the site of involvement.
Okay.
Because in the fascicle itself, the orientation of the pupil fibers are different from the other muscles. The pupil is situated more medially in the fascicle rather than the other muscles.
It's a demyelination.
No, it's an infarct only in acute onset.
Infarct usually causes a lot of altered sensorium at this site.
No, we don't. No, usually altered sensorium, there's such a thing. Usually don't have altered sensorium. Even though we are say ARF is situated, only it's a bilateral affection can produce altered sensorium. We can have bilateral third nerve involvement with midbrain without any altered sensorium.
Sir, in this patient, both midbrain lesion is also there and third nerve also, sir.
No, even in upward gaze palsy can transiently occur with a unilateral lesion. See the center for the upward case is the RIMLF. The RIMLF fibers go dorsally, cross in the posterior commissure, and come and innervate bilateral. The same from the opposite side. So an enduring or a persisting upward gaze palsy will occur only if there is a lesion in the posterior commissure, where the fiber input from both sides has to be lost, because they cross in that posterior commissure. But even unilateral lesion can produce upward gaze palsy transiently, because it has been all along, it has been bilateral conversion, suddenly one is lost. The transient upward gaze palsy, because for a time period till the other pathway takes its effect. Till that time, you can have a transient upward gaze palsy. But for downward gaze palsy, always lesion has to be bilateral. Has to be bilateral. For upward gaze palsy, lesion can be unilateral.
Sir, one doubt, sir.
Yeah.
Sir, in elderly patients, we might have a restriction of up gaze also, no, sir? Whether it's related to the lesion or it is not due to lesion, how to differentiate?
No, in the upward gaze palsy due to the old age group, you don't get up to this Bell's phenomenon, everything will be lost. The restriction will be there and all reflexively, everything will be restricted.
Okay, sir. Thank you.
Sir, I have one doubt.
Yeah.
In the Bell's, the video that you elicited, the Bell's phenomenon, sir.
Yeah.
Left eye was going up, right eye was not that much going up. So is it?
No, what I did was, see, I asked the patient to keep on looking up to the maximum possible voluntarily. Then ask the patient to close if a little bit of movement is enough to find out that the reflex movement is more than the voluntary movement. So, what the instructions I have given, I'll show the video once again. I said, keep on looking up, keep on looking. That's it. Right. Now that goes up. This is it. Right eye is going up a little bit.
Okay.
I think I have time for one more case. Shall I one more case? Okay, short case.
Yes, sir. Yes, sir.
Okay, I got another class at 10:30. So this 32-year-old man was noticed. There's no video in this patient because the patient came for video, but he did not come for video. He's noticed to be unsteady by walking for the last 1 year. No other complaint. In fact, the patient was not very much bothered about this. But the late is brought in because his mother, sisters, 2 children were having the progressive unsteadiness, and one of them died after 5 years. That is why he was brought by the relative. And examination showed cerebellar ataxia is mildly subnormal intelligence and cerebellar ataxia. The upper and lower limb, mainly on the lower. That's the finding. But the MRI brought by the patient. Look carefully the MRI and tell me what likely diagnosis is. It is hyperdensity here in the peripheral epidendal. The middle subepidendal pons is atrophied. Medulla is severely atrophied with hyperdensity in the pyramid as well as the inferior subepidendal. There is frontal subcortical hyperdensity capping the ventricle. This again zoom up view showing that pons hyperdensity in the superior subepidendal, MCP. And the medulla, you can see severe atrophy of the medulla. This is the T1 weighted showing, and the frontal hyperdensity. And this is the T2 weighted showing hyperdensity within the medulla with atrophy of that you can see somewhere in the region of polyivary nucleus, and also atrophy of the medulla.
Alexander, sir.
Late onset leukodystrophies.
Okay, we'll come back. Look at the severe atrophy of the brainstem also. Now look at this one. It's got, what is this sign
Beak
called?
appearance. Beak appearance.
No. This is the midbrain is normal, pons is normal, but the medulla is hyperintense and is atrophied. Okay. And Soumya has already told the diagnosis. What is this sign called as?
Tadpole sign.
Ah, good. This is called tadpole sign. That's like see Alexander's disease. This is see the bones and the relatively severe atrophy of the medulla and the hyperdensity there. So that and also this is another condition which produces hyperdensity in the frontal lobe. So adult onset Alexander's disease. In fact, this is from the literature showing the almost similar finding. So the medulla showing the hyperdensity atrophy. This is the dentate nucleus. Supersubilar peduncle. Hyperdensity in the medial longitudinal fasciculus here. The dentate nucleus area. Then the supersubilar peduncle. Okay. It's only out of interest I've showed the picture. Certainly adult onset Alexander. Only so the tadpole sign is very characteristic of Alexander's disease. Shall we proceed now? Okay. I'll show one more ultra short case. This is nothing great. This is a 34-year-old man from the Gulf. He has presented with severe low backache for the last 3 months. Severe, very severe low backache. He will not allow me turning in his bed. He screams with pain and the pain used to wake him from sleep. Sameness is normal except for the local tenderness of the spine. So this is the MRI of the spine. What is the diagnosis?
Tuberculosis.
Tuberculosis. He improved totally in 5 days' time with treatment. 1 week's time with treatment.
Brucellosis, sir.
Brucellosis, exactly. So this is said to be, in fact, I am not very much well versed in brucellosis. This is said to be very classical of brucellosis. The disc space is okay, but if the end plate region on either side is affected. If it was tuberculosis, we'd expect the disc region to be affected here. The disc is paired. There are also some other radiological findings to help differentiate the two. I forgot about it. So this is tentative brucellosis. SR was 30. His brucellized retina positive, and he was put on water treatment, the doxycycline and things like that. He improved remarkably. So I'll close here. Any other questions? Okay. See you next week. Am I audible?
Yes, sir. Thank you, sir.
Thank you, sir.
Thank you, sir.
Bye.